Hello everyone, this is Dr. Naz and today I'll be discussing about ventricular septal defect. Ventricular septal defect refers to the direct communication between the ventricular chambers. It is the most common congenital heart disease, that is 1 in 500 live births. So the ventricular septum develops from two separate components, the muscular septum and the membranous septum. The muscular septum starts as a ridge of tissue called the muscular interventricular septum. It grows upwards from the floor of the ventricles towards the endocardial cushion. However, the membranous septum develops from a thin sheet of tissue located just below the aortic and pulmonary valves. It grows downward from the endocardial cushions towards the muscular septum. So then eventually the muscular septum and the membranous septum fuse together, completing the formation of ventricular septum. This fusion occurs in a complex pattern, creating a solid barrier between the left and the right ventricles. So the development of ventricular septal defect can either be from the defect in the formation of the ridge of tissue that form the muscular septum, or there can be a defect in the endocardial cushion which leads to the defect in formation of membranous septum, or there can be defect in the fusion of these septums. The most common site of the septal defect is perimembranous, that is at the junction of membranous and muscular portion of interventricular septum. So the ventricular septal defect are usually associated with fetal alcohol syndrome, Down syndrome and other cardiac abnormalities. It is a left to right shunt, that is blood flows from the high pressure left ventricle into the low pressure right ventricle. This results in increased pulmonary blood flow that may lead to pulmonary hypertension. The shunt remains left to right as long as the pulmonary vascular resistance is less than systemic vascular resistance, that is the pressure in the left ventricle remains on the higher side. However, the shunt reverses to right to left once pulmonary vascular resistance, that is the pressure in the right ventricle, is more than systemic vascular resistance once pulmonary hypertension develops, and this phenomenon is known as Eisenmenger syndrome, and it leads to severe cyanosis and it is life-threatening. So this is the blood flow diagram. You can see that the oxygenated blood from the lungs enters the left ventricle, and here it is shunting to the right ventricle, and this is how the blood is mixing, but it is not causing cyanosis, or it may lead to late cyanosis because the oxygenated blood is going from the left side to the right side and not from the right to the left. So a small shunt usually produces no symptoms and resolves on its own. However, a large shunt with normal pulmonary vascular resistance can lead to formation of congestive heart failure, growth failure, recurrent respiratory tract infection due to backflow to the lungs. A large shunt with high pulmonary vascular resistance can lead to shortness of breath, dyspnea on exertion, chest pain, syncope, and cyanosis. So a VSD can lead to increase in the pressure in the pulmonary circulation. This increased blood flow and pressure in the right ventricle leads to hypertrophy or enlargement of the right ventricular muscle. This hypertrophy causes the right ventricle to contract more forcefully to pump the increased volume of blood into the pulmonary artery and lungs. The forceful contraction of the right ventricle creates more prominent pulsation that can be felt or seen as sternal heave, and you can also hear harsh blowing hollow systolic murmur with thrill at fourth left intercostal space. The smaller the defect, the louder the murmur. Because during the Valsalva maneuver there is a decrease in the venous return and cardiac output that can lead to a drop in the blood pressure. This decrease in blood pressure can result in the reduction or disappearance of the murmur, especially those which are due to hypertrophy of the ventricle. ECG may show biventricular hypertrophy. The right ventricular hypertrophy is due to pulmonary hypertension, whereas the left ventricular hypertrophy is due to excess blood originating from the right side of the heart. Chest X-ray may show enlargement of pulmonary artery, which is known as pulmonary plethora. Echocardiography is diagnostic. Other investigations like cardiac MRI and cardiac catheterization can also be performed. The small asymptomatic defect requires no treatment. Congestive heart failure can be treated using digoxin, diuretics, and surgery in refractory cases. Surgical repair is indicated when pulmonary flow to systemic flow is more than 1.5:1, that is more than 50%. Patient with infective endocarditis also require surgical repair. So the surgical repair is contraindicated in fully developed Eisenmenger syndrome. However, heart transplantation is the only effective treatment. That's the end of the lecture. I hope you learned something from it. If you do, please like my video and subscribe to my YouTube channel. Thank you so much for watching.